Hey there, it's Mike, your dietitian at the Weight Loss Institute of Arizona. And in this in-service, we're going to quickly review the gastric sleeve procedure, and then we're going to go over the role of the registered dietitian. The recent statistics from 2016, according to the National Center for Health, reports 36% of the United States is considered obese, and the Weight Loss Institute caters to that population of patients. Today we're going to focus on the gastric sleeve procedure. The gastric sleeve is a bariatric procedure that was first introduced in 1988 as the restrictive part of a bariatric surgery to treat morbid and supermorbid obesity, called the biliopancreatic diversion with duodenal switch. This provided both a restrictive and a malabsorptive mechanism of action for the patient. The gastric sleeve was the first step in this two-step procedure, and this showed excellent weight loss on its own. So as a result, around 2003, the gastric sleeve had been offered as a standalone bariatric procedure. In 2012, the American Society for Metabolic and Bariatric Surgery, also known as the ASMBS, updated its position statement on the vertical sleeve gastrectomy as a bariatric procedure. And by June 2012, the Centers for Medicare and Medicaid Services approved insurance coverage for the gastric sleeve. This was approved for patients with a BMI of 35 or higher with one or two associated comorbid conditions. With the gastric sleeve, between 70 and 85% of the stomach along that greater curvature is removed. So now that we went over the gastric sleeve, let's talk about how weight loss is achieved. So the gastric sleeve is considered a restrictive procedure because it reduces the size of the stomach, and this will cause early satiety and reduced oral intake. However, increasing evidence suggests that the gastric sleeve induces weight loss through other physiological alterations, not just restriction. This includes intraluminal stomach pressure, which causes early satiety, also increased gastric emptying for faster small bowel transit time. One interesting feature of the gastric sleeve is most patients decrease hunger following the procedure. The hypothalamus and gut hormones control hunger. While most gut hormones are considered anorectic because they suppress the appetite, ghrelin is known as the only appetite-stimulating gut hormone. Ghrelin is produced primarily in the stomach, but is also in the duodenum, jejunum, and the lung. In an intact anatomy, ghrelin stimulates the release of growth hormone and the appetite. It plays a role in body weight regulation, independent of growth hormone, by initiating food intake. With the gastric sleeve, the loss of appetite, despite a patient's restricted caloric intake, is explained by the elimination of the majority of the ghrelin-producing cells by resecting and removing most of the stomach. How we measure the patient's success after a gastric sleeve? We typically use percent excess weight loss. According to the third annual summit on the current status of the sleeve gastrectomy, the gastric sleeve shows durable weight loss outcomes. At 1 year, percent excess weight loss is 62.7, and maintain that number for 5 years. So if your patient is female, 5 feet tall, expected body weight is 100 pounds. If she weighs 300 pounds, she'll have 200 pounds of excess body weight. Her expected weight loss is 60% of 200 pounds, which is 120 pounds. Her expected weight loss would be the 120 pounds, getting her down to a weight of 180. So now on to the role of the registered dietitian in the patient's success. The RDs play an essential role in the patient's nutritional welfare because we perform comprehensive nutrition assessment to identify, prevent, or correct deficiencies. Nutrition assessments should cover both pre- and post-operatively. Dietitians also continually educate their patients on appropriate foods and bariatric products, and they offer support and strategies to overcome dietary challenges. So in terms of preventing nutritional deficiencies post-operatively, there's still a lot of research that is needed to educate the long-term effects of the gastric sleeve on micronutrient status, vitamin and mineral deficiencies, especially once the procedure is performed and reported for up to 5 years post-op. But the research has shown that patients who undergo gastric sleeve are at risk for microcytic and pernicious anemia as well as metabolic bone disease because of the micronutrient deficiencies in iron, folate, and B12 and vitamin D. Gastric sleeve reduces hydrochloric acid production and creates a significantly reduced intrinsic factor. This will directly affect iron and B12 absorption. Thiamine or vitamin B1 deficiency leading to Wernicke-Korsakoff syndrome has been reported in several cases after gastric sleeve surgery. Research has also shown that while most bariatric programs and hospital protocols agree that vitamins and minerals are important, there's variability in the prescribed vitamin-mineral protocol. A single multivitamin containing more than 100% of the recommended dietary intake may be insufficient to provide some of the necessary micronutrients. At the Weight Loss Institute of Arizona, our dietitians and surgeons recommend the patient takes a daily multivitamin with 45 milligrams of iron, 500 micrograms of B12, 1,000 milligrams of calcium, with 500 international units of vitamin D. It is important that not only the dietitians follow up on vitamin intake postoperatively, but the medical assistants also make sure these are noted in the patient's medications. Potential gastric sleeve side effects that have nutritional consequences that may be best addressed by a bariatric dietitian include nausea, vomiting, diarrhea, dehydration, electrolyte imbalance, vitamin and mineral deficiencies, protein-calorie malnutrition, anemia, adverse sensory stimulations, food aversions or food intolerances, and metabolic bone disease. The dietitian plays an integral role in identifying symptoms that may be related more to the surgical risks than dietary consequences. For example, a gastric leak, gastric ulcer, gastric stricture, and serious sleeve-associated risks that initially may present as dehydration, abdominal and back pain, nausea, vomiting, fever, and anemia. The dietitian may be the first healthcare professional who recognizes these symptoms, which reinforces the importance of having an interdisciplinary team for the bariatric surgery patient. As far as daily macronutrient intake and calorie intake, we typically will recommend the patient consume around 1,000 calories a day in the weight loss phase, which is typically the first 2 years after surgery. We're going to look for at least 60 grams of protein. However, the weight of the patient, the gender of the patient can play a role in our recommendations for protein intake. We do promote a lean protein, fruits and vegetables, moderate fat diet for the patient. We give them the dietitian supply the patients with cookbooks, meal plans, online support. We use a website called Pinterest, which is very active with over 400 members and over 1,000 bariatric surgery recipes and snack ideas. In addition, the dietitian will meet with the patient at each and every visit. Starting with their very first visit for preoperative education, they'll be given a list of dietary goals to follow and follow up with the dietitian throughout their journey here. The education and the support and the teaching of the patient is one of the most vital parts of the program for long-term weight maintenance, weight loss, and success for the patient. It's important that we promote weight loss surgery as a tool and not a magical pill that the patient can have and just lose their weight without the hard work that's associated with it post-operatively. Once the patient has surgery, the dietitians, as I said, will see them often throughout their journey, providing monthly support groups that are not only held in person but also live via Facebook Live. Our Facebook private page has over 1,500 members where the patients have access to the dietitians for support, questions, comments, or anything that they need. We also use MyFitnessPal for calorie monitoring, so the patients can give us a look into their world of eating, and we can give them some suggestions if their weight loss is slowing down, or if there's any issues at all that they need. That will give us a good idea for what they're eating. Staff members, patients, and prospective patients should have a good understanding of how to best utilize their bariatric registered dietitian to ensure the greatest chance at a highly successful outcome. Thank you.